Hello, and welcome to the Kinepict Knowledge-Based Podcast. I'm Szabolcs Osváth.
And I am Christian Szigeti.
We are the CEOs and co-founders here at Kinepict, and every month we are going to be welcoming guests from within lots of different aspects of medicine to talk with us about best practices and new innovations in the industry. Today we are welcoming Dr. János Kiss from Kinepict, who is a CSO. Hello, János, and welcome.
Hello, thank you for the opportunity. Today, I would like to talk about our work at Kinepict. As a Chief Scientific Officer, my responsibility is to organize the preclinical and clinical research. And in this aspect, we have to, of course, set up a good collaborative network to conduct our research. And today, I would like to focus on the clinical aspects rather than the preclinical. I would like to tell you the major achievements we can show up with these collaborations.
So in what countries does Kinepict have collaborations?
Well, actually, you know, as a Hungarian company, we have started from Hungary, and we have, of course, set up some sites in Hungary first. But after that, we try to reach other partners in the DACH region, the Germany, Austria, and Switzerland. And our first sites were set up there. So actually, at the moment, we have 5 collaborative sites in Germany and 2 in Austria. But also, we would like to extend our network to other parts of Europe and after probably beyond Europe. So we have set up recently a collaboration with an Italian group, and we are negotiating with other partners from the United Kingdom, also from Denmark. So we hope that we can extend our research and collaborative network soon.
This sounds like quite several sites. So what is the common ground and what is the scope of all these collaborations?
Well, actually, you know, the most important was that all these partners were interested in our new technology. So most of the partners were identified during meetings, conferences, and it was a pleasure to meet them there personally. And then they came to us to discuss the potential opportunities, the benefits, potential benefits of our technology. So a common motive, I would say, that all of these partners were interested in our technology, and they were open-minded, and they were ready to find or try new ways of collaboration or research in this respect.
So why do you think they find interesting this technology?
Well, actually, I think that our technology provides probably a response to unmet medical needs in the field of radiology and vascular surgery. There are some special needs for the doctors and the patients, which are very characteristic, like the reduction of the radiation dose, which is a very important motive. In general, the dose management in radiology, which means that if we can reduce the radiation dose or the contrast agent, the amount of the contrast agent used, it might be very beneficial for the patients, and in the case of the radiation, also for the medical staff. So they recognized immediately, based on our results, which we have published previously, that our technology has the potential to respond to these needs. And I think that was the basis of the initiation of these collaborations. Actually, I would like to tell you a few words about the ways how we can collaborate with our partners. Actually, we have developed 2 types of interactions or collaborations. The one we call is reference lab. Actually, the reference lab is not mainly for the research collaboration, but the major aim of the reference lab that we would like to spread over the radiology societies or the professionals this technology, and we would like to achieve several sites would use this technology in their daily routine operation, which means that this is the primary aim, not the research or the scientific output research collaboration, but rather a daily use of the technology. And we hope that we can get immediate feedback from these users on the positive and negative sides of the technology. We can further develop this technology. And also, as we call them, reference labs, in the future, we hope that they will provide an opportunity for other potential customers to get information or some reference on the operation of this technology. Thereby, they can judge whether they need this technology. So that is the reference lab program, I would say. And our aim was to set up reference labs in every major countries, like in Germany, Austria, and also we would like to extend this program for other countries like the United Kingdom, as I mentioned, major European countries like France, Spain, Italy, Germany, and also Poland, probably. And after that, of course, we can go to the United States as well. So that's also a possibility. The other type of interaction, I would say, is the scientific collaboration, where we try to find partners who have some scientific question, an interesting medical problem, and they believe that probably this problem can be addressed or can be solved by our technology. And these types of interactions are a bit different because the major aim is to investigate this specific question, which is raised by the partner, and after that, publish the results. Actually, we have already very nice examples. For example, we have very good and strong collaboration with Professor Andreas Manken in Marburg. Andreas Manken is a professor of radiology at the Philips University of Marburg, and also he's the head of the Department of Diagnostic and Interventional Radiology at the Marburg University Hospital. And from the beginning, they were interested in the special use of our technology, digital variance angiography, or just shorter DVA, in some special cases, like, for example, in patients with metal implants. You know, the metal implants might cause problems like the hip or knee implants might cause problems in the radiological investigations because they modify the properties of the tissue, and they have effect also on the automatic adjustments of the angiography system. Therefore, usually under these conditions, unnecessary high radiation might be used for the patients, for the studying of the patients, for investigating, examining the patients. And our paper, we have already published 2 papers with this group. But the first paper was very interesting because it showed that if we use digital variance angiography in patients with metal implant, we have the opportunity, because we have a very substantial quality reserve, so we have the opportunity to somehow reduce the radiation in these patients when we investigate these patients. I believe that we will continue this very fruitful collaboration with further clinical studies to substantiate this claim. Another very nice example of Professor Thomas Vogel in Frankfurt, who is the director of the Institute for Diagnostic and Interventional Radiology at the University Hospital Frankfurt, and also he's a professor at the Johann Wolfgang Goethe University. So he's a very well-known KOL, and we were very happy to initiate collaboration with him. He's a great expert, and one of his special interests is in the embolization settings, like prostatic artery embolization or transarterial chemoembolization of liver tumors. And we have initiated a very fruitful collaboration also with them. We have just recently submitted a paper on the prostatic artery embolization and the use of our technology in this clinical setting. And we have very promising results, and we hope that this technology, the DVA technology, will really help the work of the physicians, interventional radiologists who work in this field.
So how can the DVA technology help the embolization interventions?
So actually, one is that, the basic advantage of the DVA technology is that it can provide a much higher quality image than the DSC technology from the same rows unsubtracted series. So it means that we have improved image quality, which means that we have a kind of, we call it quality reserve, and this quality reserve can be converted to dose management, which means that we can reduce the radiation dose, or also we can reduce the amount of the contrast agents. So far, we have verified existence of this quality reserve, and in the subsequent and ongoing clinical studies, we try to define the degree of the reduction, and how much reduction we can achieve using this technology. So this is one possibility.
And what are the major fields where the technology can bring new value?
In the embolization settings, it is very important to see how successful was the intervention, which means that when you at the operating table, you have to know during the intervention whether you achieved your aim or you have to work further, because if it's possible, it would be good to reduce the number of the sessions which are necessary. It is typical that, for example, in this liver arterial chemoembolization, that patients have to return to the site several times, and they receive repeated treatments. But of course, it is good if you somehow can reduce the number of the treatments and you can enhance the efficacy of the treatments. And for this purpose, we have developed a very effective tool. We believe this is a very effective tool, the so-called color-coded DVA technology, which might be very useful to judge the efficacy of the intervention. In this, I wouldn't go now into the technical details, but the most important is that we believe that this technology might be a very good decision supportive tool for the interventional radiologist to decide on the quality and efficacy of the treatment.
And now, this is a whole big subject in itself. This could be the subject of another podcast, the color-coded DVA. But so there's a quite large number of interventions done in the lower limb. How does DVA provide value for these? How could you test this in the reference sites?
I would like to emphasize that, yes, we have started our work in Hungary, as I mentioned at the beginning of the podcast. And our first and probably most important scientific advisor, Professor Péter Sotonyi, who is the chair of the vascular and endovascular department of vascular and endovascular surgery at the Semmelweis University. He gave us very, very useful advices concerning this technology and the potential benefits of this technology. And we have initiated a lot of studies with them, and also with Professor Balázs Nemes, who is the chair of the Department of Interventional Radiology, also at the Semmelweis University. Both of them work at the Heart and Vascular Center in Budapest, which is a major tertiary vascular center in Hungary. And they gave us a lot of good ideas and advice how to continue the development, and also how we can use this technology in peripheral artery disease patients. And one direction was that we have initiated studies on the potential reduction of the radiation dose in peripheral artery disease patients. And we found that our technology provides an opportunity for at least 70% reduction without compromising the image quality of the angiograms. And actually, they have already started to use this technology, especially in carbon dioxide assisted angiography and interventions, because in that case, our technology has major advantages, a much better image quality and a lower radiation dose because of the lower frequency which is required for generating good quality images in these carbon dioxide assisted angiography. And during these studies, we have observed that we have, and the technology has a special advantage at the lower parts of the lower limb, especially in the crural and talocrural region, because DVA is able to visualize the small vessels much better than DSA technology. Therefore, the interventional radiologist can make much better the therapeutic decisions, where to intervene and what to do with the specific lesion. One of the major advantages of DVA is that it can enhance the safety and efficacy of the below the knee interventions, which is very important because usually when you would like to prevent major complications of the peripheral artery disease like amputation of the lower limb, these regions are first affected, and therefore these are critically important for the limb saving interventions. And in this respect, DVA performs perfectly. And as I mentioned, this technology is already used in the daily routine at the Heart and Vascular Center. And they use it for the patient's diagnostic and also for the therapeutic interventional procedures and the vascular procedures. As you saw from these, what I told you, for us, it's very important to develop collaborative research network because it is very important for us that this technology should be validated in more and more diagnostic fields or more and more indications. And therefore, we are constantly looking for newer partners. We are looking for partners in the field of, for example, neuroradiology, because we are also interested in these applications, and also in any other potential use of the DVA technology. I would like to tell you that we are open for collaborative ideas. We welcome these potential inquiries.
Thank you to all our listeners for joining us today. And a big thank you to János from Kinepict for sharing your insight and wisdom with us. If anyone has any questions, throw or comment about the things we have discussed in today's podcast, be sure to get in touch with us. Looking forward to catching you all next time when we welcome another inspiration guest to the Kinepict Knowledge Based Podcast.
Hello. Bye.
Bye-bye.
Bye.
Bye.